I'm Dr. Dinesh Havelia, consultant dermatologist from Kolkata. I'll be speaking about psoriasis to you all. Psoriasis, as you all know, is a chronic autoimmune disease which is involving the extensor surfaces of the body, mainly bilaterally, symmetrically. Like common sites of involvement are elbows, knees, scalp, palms and soles, and there are many variants of psoriasis also. Like they may be confined only to the nails or only to the scalp or only to the intertriginous areas, which we call inverse psoriasis. It presents as erythematous, that means red scaly plaques, particularly on elbows, knees, scalp, back, or other parts of the body, which we call plaque type of psoriasis. It may also have other manifestations like drop-like scaly plaques can also be there on the entire back, which we call gutted psoriasis. Other variants are also, just particularly nail may be involved. Nail becomes thick and scaly and there is subungual keratosis. So there are so many variants. Sometimes psoriasis, if mismanaged or sudden stoppage of topical steroids, lead to generalization of the psoriasis, which we call erythroderma. That becomes an emergent issue. Sometimes we may have to admit the patient and give supportive management, as well as there are certain specific medications for that. There are certain triggers which can aggravate psoriasis, like if the patient is on certain drugs, lithium or chloroquine, or on alcohol, smoking, all these are triggering factors. Or you have particular stressful situation. So stress can trigger also. And even during pregnancy, sometimes the generalized body involvement may occur in psoriasis. Or somebody is taking systemic steroids. The moment you stop steroids, psoriasis can aggravate furiously. Since it is an autoimmune disease, it is not only skin deep. It can involve other parts of the body also, particularly joints. So that is called psoriatic arthropathy. And this, every physician has a duty to rule that out also while taking the history of the patient, because psoriatic arthritis is quite disabling. Psoriasis, as I was saying, is not only skin deep, it can have repercussions on other parts of the body also. It is associated with various metabolic syndromes, like more prone to have diabetes or hypertension or other cardiovascular mortality. So this also we have to keep in mind. So every time we see the patient, we have to see them as a whole to rule out other system involvement too. And we can categorize psoriasis as mild, moderate or severe according to the body surface area involvement. Like if it is less than 3% of body, we call it mild, 3 to 10% we call it moderate, and if it is more than 10%, then we call it severe. So majority of the patients are mild to moderate in severity, and they can be very well managed by topical therapies. Now amongst topical therapies, we have topical corticosteroids, topical calcineurin inhibitors like tacrolimus or pimecrolimus, or topical calcipotriene inhibitors like calcipotriol. So many patients can be managed with these alone. Of course, moisturization is the key. So every patient needs to moisturize properly to get the better effect. And moisturizing using properly can also have steroid sparing effect. Once the disease is under control with these topical modalities, we can cut down the doses of steroid by prescribing only on weekends, that is Saturday and Sunday, and other days we can manage either with moisturizers or with topical calcineurin inhibitors to avoid side effects related to topical corticosteroids. Apart from these topical modalities, we have systemic treatments also. Now we can have conservative mode of treatment or biologics. And conservative treatments mostly have been used like methotrexate or cyclosporine or acitretin or this apremilast. Problem is that they do not have as much efficacy as the biologics, though they are gold standard methotrexate for the sake of it, but they have also some kind of side effects like methotrexate is, you have to be careful about liver toxicity. When you are prescribing cyclosporine, then renal toxicity has to be kept in mind. Acitretin we cannot prescribe to childbearing women because it has got an impact on pregnancy and teratogenicity, and they can also increase the lipid levels. So if the patient has propensity to develop cardiac attacks or cardiac problems, then we have to be really careful in prescribing cyclosporine or even acitretin. Apremilast is relatively safe, but it also can have certain psychological issues if you prescribe, and many patients may not respond, and they take a lot of time to show the response. Problem with these conservatives is again one that there is a slow response apart from cyclosporine, which we use as a quick fix agent. Then comes the biologic part of therapy, and they are basically protein molecules. Here the beauty is that they target a specific pathway of psoriasis. So attendant side effects are very far and few between. Only infection we have to be careful, and there are certain tests which we have to undertake before prescribing biologics, and there are many biologics available to us in the market. They give a very quick response, and the response can be sustained for a long time if the patients are on biologics, and they're relatively much safer than the conservative agents. So that gives the very good quality of life, quick action, long-lasting remission. All these are very big virtues. Only downside is the cost of the biologics, which also again is coming down since the previous years. So there is a good ray of hope, and many more are in pipeline. So we are quite hopeful that in future we'll be able to manage psoriasis quite effectively.